Bienvenue. Je dois avant tout remercier le comité d'organisation qui me fait l'honneur d'être premier modérateur, alors que je n'ai rien à voir avec l'implantologie. Je l'ai dit tout de suite, je ne suis pas dentiste, mais c'est par amour filial que les comités d'organisation m'a fait cet honneur de m'inviter. And I would like to introduce Dr. Elaskary, qui va nous parler de la gestion de la table osseuse vestibulaire dans la thérapeutique de l'implant immédiat, Debrief Conference.
So good morning. Bonjour. Sabah al-Khair. I am honored to be here today, and I would like to thank the organizing committee, especially Dr. Raja and Dr. Kroof, for this invitation. I really enjoyed this place very much, and I enjoyed the company of many warm, nice, kind people. I really think that the organizing committee has put a wonderful program for everyone to enjoy today. And the best thing that we are focusing on one topic, which is fresh sockets. So please pay attention, because you will see stuff that really influences your practice today. What are the benefits of placing dental implants in fresh extraction sockets? Immediate aesthetics, shortened treatment time into half, accelerated soft tissue healing, something that we keep seeing during the practice. However, we would like to pay attention to complications. Complications, ladies and gentlemen, do occur. We need to know how to handle. We need to know how to avoid these type of complications to happen. What about factors that influence complications? I think that the main factor for increasing or influencing the complications is the lack of skills, as well as the lack of diagnostic tools, pathology in the socket, and the core, which is the labial plate of bone. And that is my topic today. I'm going to focus on the labial plate of bone. We believe that the main influential factor that influences the treatment, especially in fresh sockets, is the labial plate of bone. The value of the labial plate of bone to any treatment is immense. The achievement of ideal aesthetics would probably arise by having an intact, healthy labial plate of bone. We classify the labial plate of bone into three classes. Class 1, which is thick. Class 2, which is thin. Class 3, which is absent. Therefore, we need to put in mind that the majority of the labial plate of bones are absent. The majority of them. Or thin. Rarely we find thick labial plate of bone, according to the literature. All of these are clinical features that is linked to the absence of the labial plate of bone. We call this labial plate of bone is the alveolar bone proper, and it's called cribriform plates in some expressions. It's made of cortical plate on the outside, which contains partly lamellar and partly of bundle bone. This bundle bone, it gives an attachment to the fibers of the periodontal ligament through the numerous minute foramina. It's called Volkmann's canals. So these are the origination for the periodontal ligament. This is a histological section that shows this is the periodontal ligament, and these are the fibers that attach to the bundle bone. This is the bundle bone here, and this is the first bone that starts to resorb after tooth extraction. The blood supply that comes to the labial plate of bone comes from periosteum, from endosteum, and from the periodontal ligament. Lamellar bone is covered by areas of bundle bone. However, this bundle bone, it's the name is taken because of the bundles of the principal fibers continue into the bone as Charpis fibers, as we all studied before. However, there is no evidence that bundle bone lead to complete resorption of the labial plate of bone. We don't know. We think that the main reason behind the resorption is the existence of the bundle bone. The question will arise, what happens to the labial plate of bone after tooth extraction? What really happens? Simply, the question is, as soon as we have taken the tooth out, there is an osteoclastic activity that starts right away on the internal aspect of the labial plate of bone. These are accelerated and being and started just because of 3 reasons. Number 1, loss of Charpis fibers. Why loss of Charpis fibers? Very interesting information is that those fibers contains something called the myofibroblasts. Those myofibroblasts gives a continuous traction and relaxation that maintains the integrity of the bundle bone. So these type of function of the myofibroblasts that exists within the fibers that gives the existence and maintenance of the labial plate of bone. So once you take it out, then the labial plate of bone starts to degenerate. Then the nature of the labial plate of bone being thin, being compact, that leads to more resorption, as well as the blood supply. Once you take the periodontium out, the periodontal ligament, then labial plate of bone starts to go away. Then you end up with this. This is a physiologic procedure that we cannot interfere with or we cannot stop. It's something just physiologic. This is an article that is published by Myron Nevins et al. And it stated that in 41 days or in 42 days, something like this, some of those prominent roots that has thin labial plate of bone just go away. Only in 42 days. There is a significant resorption that is 6 millimeter in height that occurs. Today we are here to learn how to handle all of these, how to clinically manage these, how to stop these from happening, and how to treat these when it started. The factors that influence the labial plate of bone are physiologic and clinical. Now I will cover the physiologic. The physiologic factors started with the thickness and density. For the labial plate of bone to stay in place, we need a minimum thickness that is being stated in the literature, which is at least 2 millimeters. Some authors stated that it's 1.9 millimeters needs to be there. This is the minimum thickness that needs to maintain the existence of the labial plate of bone. An interesting study that I just read recently that evaluated 125 scans of the labial plate of bone, and the conclusion of this study was that the labial plate of bone of the maxillary teeth was thin or missing in 90% of patients at the crest. Can you imagine this? When I read this, I really got very excited. How come? So we are dealing with a very delicate structure. We are dealing with something that is totally unpredictable. We really need to learn how to manage and treat this labial plate of bone defect before we even preserve it, because it's already not there. We start with 90% of the cases it's missing. Density. What about the bone, labial plate of bone density? Density is also a factor. Why? Usually the cortical plate of bone labially have very less marrow spaces. When you have less marrow spaces, then you have less blood supply, then you have higher values for more resorption. So the more you have dense bone, the more you have liability to bone resorption. What about the soft tissue thickness? An interesting publication that stated that the initial gingival thickness may be considered as a significant influence on the marginal bone stability around implants. They stated that if the tissue thickness is less than 2 millimeters on the crest, The bone loss expected up to 104.5. What about preosteal reflection? Preosteal reflection has been covered by Botticelli, by others, by Nubutu et al., by many others. The idea behind the preosteal reflection is that once you reflect the preosteal flap for placing the implant, immediately we expect 65 or 56% of the bone resorption might be anticipated. This is according to Botticelli. Why is that? A lot of authors have explained it because of the interference of the microvasculature of the preosteum. Then once you have this circulatory insufficiency occurs, then bone resorption starts. And this is another contributing physiological factor for bone resorption. Here is it. Once you take the tooth out, intact labial plate of bone, once you're just by reflecting a little bit of the preosteum, this is what we anticipate here. You start here, you started to lose 0.5 millimeter in the height of the papilla just because of the reflection, preosteal reflection. Another very important issue in losing the labial plate of bone is the physiological post-immediate implant placement bone resorption. Araujo et al. From Brazil and Lindy, they have described these 5 articles that no matter if you place the implant or not, you are going to end up losing bone, labial plate bone. So dental implants do not really stop bone from resorption. What happens is that this is what you have, you start with, and this is what you end up with after some time. I started to follow those cases that I do. I started to see what really happens. This is a remaining root to be taken out. This is a totally intact labial plate of bone. Implant is being placed, and then this is 3 months after implant placement, and then we started to see this. This is the I really didn't know. When I see this, I didn't know. I say, is this soft tissue drop or this is a bone insufficiency? I remembered very well at the time of implant placement that I really did the protocol. I scratched the labial plate bone. I measured the thickness. Everything is fine, great, but this is what I end up. So I was really confused. What is the reason? Is it the soft tissue or the bone? Believe it or not. So how many cases did we do in the past 25 years of implant dentistry that has no labial plate of bone? And we thought that it was there. A lot. Once you have a thick phenotype, you probably do not anticipate labial plate of bone resorption. But once you have thin biotype, definitely you will anticipate 100% of post-immediate implant placement bone resorption. This is a very good clinical evidence that when you have bone in thick biotypes, when you have bone resorption, it is not necessary to have recession and apical tissue migration of the soft tissue. This is the typical condition of this. This is the same case before reflection of the preosteum. There is no recession, but there is labial plate of bone resorption. There is, in this thin biotype, when you lose the bone, you definitely have the soft tissue migrate along with it. Any thin biotype like that, I place either a connective tissue graft or acellular dermal graft along with the time of the surgery. Now we shift to the clinical factors that leads to labial plate of bone resorption. Clinical factors are easier. Why it's easier? Because it's easier to avoid. I can easily avoid those factors. One of those factors is the lack of experience. I have seen many problems arise from the mishandling of the immediate implant placement. I see those type of work on daily occurrence. So this is how we handle some case like that. I usually prefer to recreate or re-graft the area and install the implant in the same time. I used non-staged approach in 95% of my cases. I will show you why later on. And this is now the integrity restored of the labial plated bone. This is the surgery. This is the improvement of the labial profile, and this is the final case restored. With a little bit of recession, of course, because we already started with loss of the labial plated bone. What about labio? Too far to the labial placement of the dental implant. This definitely lead to, according to the literature, to 3 times more recession. Why? Because usually the labial plate of bone is being pushed and interfered by the too far to labial implant position. This is a case that is being done, I think this is 10 years ago or 12 years ago. 9 years later, this is what we have seen. Because of this implant is being too far pushed out to the labial plate of bone and being placed on a flapless manner, which is a little bit risky, this is what we have done. We found out that the implant itself is totally out of the bone. And then this is, again, the complete restoration of the integrity of the labial plate of bone. This is before and this is after. And you can appreciate the difference how the too far to the labial plate of bone influences the outcome of the implants. What about that wide implants? 12 or 15 years ago, we used to think that, well, we should use wide implants as close to the socket walls as possible in the front zone. Well, nowadays, I don't think we should do this anymore in the front area only, at least. Why? Because we have the evidence from the literature and we have the evidence also from the clinical. Here is a July 2006. This is a case that we have done. At that time, we think that the wider the better, and we use these 2 implants here. Then excellent aesthetic outcome, September 2006. However, in 2007, this young lady came back with this type of discoloration. Complete loss of the labial plate of bone. Then we augmented the area, we augmented the soft tissue with acellular dermal graft, we closed down, and this is before and that is after. There are some other factors that include soft tissue thickness, that implant color, texture, and the tooth shape itself, and I'm not going to go through these aspects today. Okay, now we move to the second part of my presentation, which is technical questions. Now, we need to know some technical questions. Number 1 is, does flapless implant placement in fresh extracted sockets help preserve the labial plate of bone? So do we put the implant on a flapless fashion, or do we do a flap? Does it have any clinical advantage? The answer is yes and no. The answer is yes, you can, but you need to follow a strict, very strict guidelines. Why? Because there is, according to the literature, there is the flapless implant placement. So you save a lot by not opening a flap, by placing the implant in flapless fashion. But definitely, you have to follow the guidelines strictly once. Number 1 is to inspect the labial plate of bone integrity. You have to inspect it either by CT scan or visual inspection and probe inspection and exploration. Number 2 is that you really need to take this tooth and removal of the remaining whatever hopeless root out without any laxation to the labial plate of bone. Just do rotational or do peritomes, or you use extractors, special type of extractors, whatever. And in those type of cases, when you restore a case like that, this is the case restored. But what is this question mark here? I would never nowadays do a case like this without placing a connective tissue graft, because I know that this looks very nice today. 1 year later, come back, these tissues will migrate up and you will end up having recession, because this is a thin phenotype of oral tissues. Another question, does connective tissue graft has any clinical value other than aesthetic? So what is the value of the connective tissue grafts? The value of connective tissue grafts being recently, 2011, it's an article that is published by Uli Grunder. He get 24 patients, divide them in 2 groups. One of the groups received connective tissue grafts at the time of implant placement via tunnel, and the other one did not receive. He stated that in grafted sites, the overall volume of the tissues has a gain of 0.3 labelly over 1 year period. In non-grafted sites, it shows loss of 0.6 tissue volume. So therefore, I really recommend the use of the connective tissue grafts along with implant placement, especially in phenotypes, thin phenotypes. I use sometimes acellular dermal grafts. We put acellular dermal grafts here just to improve the socket, the soft tissue area. And then this is connective tissue grafts. And sometimes we apply it from the crevice here to improve the emergence profile. How far do we place the implant from the labial edge to the shoulder, to the labial plate of bone? How far? This is, how far can we manage this gap? The answer still comes from the literature. And interestingly enough, implants placed closer to the buccal plate of bone is associated with increased crestal bone loss. Believe it or not. Large wound space led to enhanced bone regeneration. This is something that we have to keep in mind, and we have to put it in mind, in consideration. Validity of socket preservation therapy. I'm not sure who's covering this topic today, but I'm sure that we are going to have a big deal of talk. Why? Because I think that there is no use for the socket preservation therapy unless we have a real destruction of the labial plate of bone. Why? I used to give this slide 2 years ago without any scientific documentation. What I think is that when you put the bone here at the time of tooth extraction, then later on the labial plate of bone starts to undergo resorption, while the bone itself did not mature enough to become bone. So placing the bone at the time of tooth extraction will never stop the labial plate of bone from resorption. So you will end up all the time having loss of volume. So there will not be any help from the socket preservation. I'm sure that half of you will disagree, but this is what I have read recently. This is an article that just published. I think this was published 2000 this year. And when I saw this article, I was really thrilled. Why? Because this is an article that evaluates to determine whether the ridge preservation using osteoinductive allograft would prevent ridge resorption or not. The conclusion was, first, test and control sites, they lost similar amounts of alveolar ridge. So it means that it's useless. Both of them lost similar amounts of bone. Thicker buccal plates of bone, yes, definitely associated with less ridge loss. This happens in both of them anyway. The percentage of the new bone was not statistically significant between either test or control sites using either micro-CT or histological analysis. This is, for me, solid as a rock. This has come as a confirmation. This has not really come as something else. It really confirms my notions in regard to socket preservation therapy. Do we place the implants staged or non-staged approach? Unless I have some primary stability, then I build everything on top of that. It avoids, it cuts the treatment time into half. It avoids provisionalization issues. It minimizes the number of surgeries. It really, I think it's equal. We need to have a study that compares, but this is my clinical notion. What type of grafting material should we use in the socket? Is there any good grafting material? Well, the literature said this is 3 grafting materials comparison. It says no, there's not really a value, all are fillers. However, this is a recent study that's being published just this year that evaluated what is better, decalcified freeze-dried bone or just freeze-dried bone. And they think that the decalcified freeze-dried bone gives a faster bone formation. So this is something that, we just take as a reference. in my view, I think they are all alike. Dennis Turnau did not put a bone for a gap distance of 3 millimeters and it just healed up. It's just one case, yes, but it's an evidence. It cannot be taken as evidence, but it's there. What type of bone graft substitute should we use? I think I would share today with you some of my experience of 20 years. This is July 2005. This is a case that I decided to take these two teeth out, and this is the type of defect. This was July 2005. At that time we put the implants, bone, membrane tags, membrane, everything, and things were really brilliant. At the end of the year, everything was really nice. Implants there, bone there, everything is fine, soft tissue is augmented, and then we came back 3 years later. What happens here? Then I started to think what really happens. What really happens is that the unpredictability of the bone graft materials. Maybe probably 95% of the bone grafting materials, either alloplasts or allografts, they are all unpredictable. So we have to take an autograft and place it there in order to, and connective tissue graft of course, in order to improve this situation. I can share with you, this is now 1 week later, this is May 2009, we follow this up for a long time until December 09, and then everything is there, labial plated bone was intact. Another example, excellent grafting technique. We put whatever type of bone graft, membrane that is totally stabilized, soft tissue closure, and then this is poor regeneration. Another example, this is at the time of implant second stage surgery, we scoop out the bone graft material. We just scoop it out as any other thing. We scoop out the bone grafting material, it's not there anymore, or it's there but it's not doing any type of vital bone. Although of all those type of histological sections that we see and stuff like that, I believe that it's not vital. I believe that those type of materials are not predictable. Simply enough, they are not predictable. So my lessons, ladies and gentlemen, will learn. I'm sorry to say that I'm not really using these type of grafting materials anymore a lot. So what is I really use? The lessons first. Lessons are not all what appears to be radio-opaque is bone. Doesn't mean that you have an X-ray and things are fine. This means it's a vital bone. Number two is that an outstanding immediate post-operative result never give an impression on the final overall success, even if it revealed primary success. Number three, there is no such a perfect research out there that investigates all of these types of materials, grafting materials, and compares them together in the same mouth. This is not going to happen. At the end, our clinical experience would judge. So my golden choice, not even the block graft. My golden choice is either the bone scrapers or those harvesters. That's it. This is what I really use. Of course, I'm not using those suction harvesters because these are definitely leads to contamination of the bone graft. But this is what I use. Either this or that. I can get the extreme good amount of bone and I particulate it and I use it. Definitely, it gives me a great osteogenic capacity. Guess what? I just found out that this is really backed up either from the literature. This is a question, does the method of bone harvesting affect the osteogenic potential or the osteogenic of the graft? Yes, they had four ways of bone harvesting. By milled bone graft, block graft, or bone chips, or bone slurry from trap, or bone from piezosurgery. And then the conclusion was the best type of osteogenicity of the bone graft is either using by the bone mill or by the bone scraper. It gives a lot of osteogenicity at the day 5 from harvesting, which really give me a great pleasure that this is back up from the literature. Then the question will be, Do we close the soft tissue on top of the implant as we used to do before? Of course not. Also backed up from the literature, we don't do this anymore. We don't do any soft tissue closure anymore. Do we use those type of fancy, they call this static flap, buccal flap, whatever? We tried this and the same recession that we started with. And this is something that does not stop those materials, those soft tissue margins from recession at all. So this is something that we do not really even use. So now the final part of my presentation, how to manage the labial plate of bone. We really need to see how to manage the labial plate of bone. We know that we have 3 types of sockets. The very simple classification into type 1 when you have a intact soft tissue and bone, type 2 when you have intact soft tissue but bone, and type 3 when you have loss of the soft tissue and bone together. This is the 3 types, very simply, and each of them has a certain way of clinical handling. Type 1, we usually use acellular grafts or connective tissue grafts. Type 2, guided bone regenerative procedures should be followed either with or without implant placement. And then type 3, the gold standard is the forced extrusion with or mobilized osteotomy interposition of the graft. Well, I'm going to show what are the requirements for the ideal grafting approach. We know that we all see in the literature and in the clinics, we see block grafts and we see how to cut the block grafts and stuff like that. But I have a special philosophy for the ideal requirements of the graft for the labial plate of bone. It needs to be osteogenic. It eliminates screw fixation. I don't really want to use a lot of titanium screws because of the hassles, and better adaptation to the host bed. No possible injury of the adjacent teeth from the donor side, and then it mimics the labial plate of bone contour. Something that is different, something that is out of the box. I show you today something that is going to be published the J. Perio next at the end of this year. It's something called fitted autogenous bone lumineers to repair the labial plate of bone. I developed this technique 8 months ago in order to restore the integrity of the labial plate of bone. The idea is that we prepare the defective socket, and then we had a platform that will receive this fitted block. This is how we use it. We prepare the platform with a burr just to allow smoothing the surface out. And then I just go to the chin or whatever place, retromolar area. I harvest a piece of bone and then I prepare it with a burr with 2 slots, and then I snugly fit it to the labial plate of bone, and then I push it in and then I cut the excess. This is something that we use without any screws. I used here a screw because this was my first, this is a membrane tack either, because this was my first case, so I thought that let me try to fix it. And then this is the case after the profile. This is the CT scan that's showing the complete integrity of the labial plate of bone, and I followed this case up to 6 months. The plate is there, everything is there, everything is excellent. This is the case restored. And then this is another case that has even more labial plate of bone resorption. I prepare the platform, and then I get my perio probe just to measure the defect size, and then I harvest my piece of bone. At this time we went to the retromolar, the ascending ramus, and then I just had this piece of bone, very nice, and then I placed the implant at the same time, a narrow implant size of course, and then I snugly fitted this piece of bone. And this is the bone, and this is the integrity of the labial plate of bone. This is the case finally restored. Beautiful, stable soft tissue margins. This is a failed implant, and you can see even the soft tissue is not there anymore. Bone is not there. What happens is that we removed the total implant, and then we started, look, this is a fistula here. So we remove the implant totally. And then we cleaned it up very well. And then we prepared the platform. And this is the type of graft shaped, and this is being snugged into there. And I placed a connective tissue graft on top of that just to enhance the soft tissue quality. Here is before and here is after, and you can see how nice is the keratinized mucosa formation. Here is the labial plate of bone with the CT scan showing, this is a 3D dimensional showing the graft in position. Here is the place. This is even a larger case. This is a total absence of labial plate of bone. We used also this snugly fitting bone lumineer. We cleaned everything up. And then this is the piece of bone that we push down. We hammer it sometime just to keep it really in place, and then we cut, and then we take the excess to the other side, and as you see here we put 3 pieces of bone in there. CT scan showing beautiful integration of this material into the labial plate with extremely nice bone architecture on top of that. Even the soft tissue is being totally enhanced, and finally the case restored. But the questions comes, but I still do not like this procedure. I cannot do it for myself. Why? Because first, harvest technique is still inconvenient to the patient. Patients wants to come to the office, have a small or maybe an invasive procedure, not that invasive one. Procedure is still time consuming in my hands, and it's not tolerated by many patients. Not all of you will do it after we go out, after we leave this meeting. Not all of you will do it, and it's not considered to be a routine office procedure. So what's the solution? The solution comes from a new device and a new technology. It's called PDLLA. It's amorphous non-crystalline polylactic acid material. I took the privilege to develop this material and to develop this technique. It's a shell that we use to carry the bone and to improve the labial plate of bone integrity. It leads to outstanding results that eliminates a lot of patient discomfort and a lot of stability to the bone graft materials. I apply these material in all of these type of cases, in all of these type of defects. This is how we use it. We put it in a bath, in a water saline hot bath, and then we put it there. This is the screw fixation, and this screw by thermal act, we melt it in place until it fell down, and the other side we put another screw, and then we develop this carrier to we put the bone harvesting inside of this carrier, and then we fit it in with the same device. Here is the shape after we finish, and this is a CT scan showing the bone graft material there. I only use the bone scraper. There, and this is actually 3 months time. We open up again to treat these type of implants. So by the time we saw what happens there after 3 months and 10 days, bone is still there, screws are still there, everything is fine. It's going to resorb after exactly more 3 months time. So in 6 months time, it's not going to be there. It's going to be replaced by total bone. This is another case that we put some, there was an implant that is being previously placed. We removed the flap, and we put 2 screws here and 2 screws up there, and then we covered it with labial shell from this PDLLA, and then we closed down. We usually do surgery with a microscope. I try to be as aesthetic as possible. This is the complete restoration of the labial plate of bone on CT scan. And that's how I developed another set of treatment kits. It's called the socket repair assorted kit. This is something that you will see recently in the market. It's something that is a carrier like this. You put it in this handle and just you put the bone grafting material in it and you stick it in place with this type of sonic weld stabilization. Something that really will help you very much in your practice easily to restore a defective labial plated bone. This is 3 screws placed in place. This is the socket protection, and we put the bone underneath it and we close down. CT scan showing beautiful integration and stabilization of the bone graft in place. This is the case before, and this is the case after. You can see the complete restoration and of the soft and hard tissue, both of them. And then this is the case finally restored. Beautiful soft tissue integration. I followed this case for 6 months only, and you can see this is before, this is after. Bone is still there, everything is fine, no creeping of the soft tissue or the bone. Now, my final stage of this presentation is that I would like to share with you some of what happens with the critical cases, critical bone graft, labial plated bone resorption. What do we do with such cases? In those type of cases, we usually take an individualized approach for each case. Soft tissue work and bone work and graft work. For this case, we tried to use a double papillary action maneuver in order to first improve this recession and implementing those soft tissue rules. Here we took a pedicle soft tissue connective tissue graft from the palate on a pedicle basis just to improve the vascularity and the mobility of the graft. As you can see here, we just try it, and then we do the V-shaped incision on both sides in order to approximate the tissues. And then we check that these tissues are